and welcome to our session titled, Do You Know the Real Cause of Your Kidney Disease? Why it is important you know, and how to find out. I'm Janitra Collins, Director of Professional Education at the American Kidney Fund. This session was created as a result of AKF's Unknown Causes of Kidney Disease project. So we'd like to thank all of our sponsors who support and make it possible. While 37 million people in the United States are living with kidney disease, a portion of these individuals are uncertain about their cause. Understanding the cause of kidney disease can impact many healthcare decisions for patients and physicians. Today, our panelists will discuss the impact of a diagnosis, options for genetic testing, and resources available to navigate challenges throughout the process. Now let's meet our panelists. First, we have Dr. Orlando Gutierrez, an AKF Clinical Scientist and Nephrology Fellow from 2006 through 2008. Dr. Gutierrez is currently a professor of medicine, a Marie S. Ingalls Endowed Chair in Nephrology Leadership, and director of the Division of Nephrology at the University of Alabama at Birmingham. Using both epidemiologic and patient-oriented clinical research approaches, the primary focus of Dr. Gutierrez's group has been elucidating the mechanisms by which disorders of bone and mineral metabolism and nutrition impact outcomes in individuals with chronic kidney disease. His group has also focused on how environmental and genetic factors impact disparities in cardiovascular and kidney disease. Dr. Gutierrez has a track record of publications, including feeding studies using physiological endpoints and other high-impact studies that have highlighted the associations of nutrition, obesity, metabolic disease, and environmental factors with outcomes in the general population and in individuals with chronic kidney disease. Thanks for joining us, Dr. Gutierrez. Next, we have Holly Bodie. Holly is the Vice President of Government Affairs at the American Kidney Fund, where she leads federal and state advocacy and public policy efforts. Before coming to AKF, she worked at the Alliance of Community Health Plans, where she directed their federal lobbying and communications work for nearly 5 years. She also worked at Washington Council Ernst & Young and at United Health Group, where she coordinated the federal affairs strategy for United's Medicare and Medicaid products. Holly also worked on Capitol Hill for over 9 years for various members of the U.S. Senate and House of Representatives, as well as 5 years at the Department of Health and Human Services under Secretary Donna Shalala. And finally, Kevin Schnur. Kevin began volunteering for Alport Syndrome Foundation, or ASF, in 2012 at age 26 after experiencing unexpected renal failure due to Alport syndrome. He was previously misdiagnosed with benign familial hematuria. After 2 years on dialysis, he received a living donor transplant from a close friend in May 2014. Kevin's desire to help others in the rare disease community led to his position at Alport Syndrome Foundation's Alport Syndrome Foundation social media specialist in 2014, part-time patient outreach coordinator in 2016, and full-time director of communications and patient engagement in 2019. Kevin has served as ASF's associate director since January 2022. He has facilitated the team program at ASF Alport Connect meetings, represented ASF at various patient advocacy events and conferences, and co-moderates the ASF Facebook support group page. Thank you all for joining us today. Now, before we get started, I want to encourage everyone joining to please type your questions and comments into the chat box. We will try our best to get to your questions during our Q&A segment at the end of this talk. To start us off today, I'd like to turn it over to Dr. Gutierrez to provide an overview of the different causes of kidney disease and how identifying the cause can impact important decisions. Dr. Gutierrez.
Thank you so much, and it's a pleasure to be with you this evening or afternoon. So there are a number of different causes of kidney disease, and the most important ones can be seen on the screen at the moment, and they include the most common cause of kidney disease in the United States and increasingly across the world, which is diabetes. High blood pressure is listed as a cause of kidney disease in many cases. Glomerulonephritis, or inflammation in the kidney due to an autoimmune process, is another cause. And then there are other causes that really represents the spectrum of kidney disease in which it's either a mechanical issue or an anatomical issue. or unknown, in which we're not quite sure what the cause of kidney disease is. Next slide, please. It's very important to know what the cause of your kidney disease is, and we can list several different reasons for that. One, it can help us further understand the progression of the disease. So if you know what's causing it, you can predict what your likelihood of having worsening kidney disease will be. It will certainly impact treatment plans. It's very hard to determine how to treat something in the kidney that's going on in the kidney if you don't know what the initial cause is. It can also influence family planning decisions. If you have a type of kidney disease that runs in the family, because it may be genetic, for example, that's important to know, both for you, your children, and potential grandchildren. And it also allows you to share information with other family members who may be at risk as well, so that if you have a type of kidney disease that runs in the family, you'll want to let other family members know so that they can be screened. Next slide. Now, a lot of times we can find a cause for the kidney disease by doing genetic testing. And genetic testing is becoming increasingly more common and available for individuals in the general public and in clinical practice. And in fact, there are several commercial products that are available nowadays. And this can be done fairly simply using blood or buccal cells, which is basically the cells lining your cheeks, that can be retrieved by using a swab or saliva. Oftentimes, physicians' office, particularly if you're seeing a nephrologist for your problems, will have these kits in their home or have these kits in their office, and they'll allow you to take them home to be able to get what you need, whether it be getting blood drawn or the buccal cells, and they can send that in to get further testing and to find out if you have a genetic cause for your kidney disease. Next slide. Now, there are a number of challenges to getting genetic testing and counseling. One of those is that at this point in time, at least, it's not widely covered in public and private healthcare. So you have to discuss that certainly with your healthcare provider to understand whether the test that you're going to get is something that you may have to pay out of pocket or may be covered by your insurance. There's also a lack of uniformity in terms of data collecting for genetic testing in kidney disease. By that is different types of tests that are out there will measure different types of genes or will measure whether you're carrying different type of potential genetic mutations, and the type that may be most familiar to you or the type that most important for you may not be the one that that particular test covers. You just have to be aware of that when working with your healthcare provider to choose which test is best for you. And then finally, there's limited provider awareness a lot of times. A number of either primary care physicians or nephrologists in the community might not be aware that these tests are available. So that's important for you to discuss with them and see what is available in your area and whether you can get to a provider who has this testing available. Next slide.
Dr. Gutierrez, I have a question for you. Can you share a little about how providers decide what different types of genetic testing to pursue?
That's a great question. A lot of times providers will use things like a family history or a type of presentation that the patient may have when they come to the clinic. If there is a particular type of kidney disease that runs in the family, that will help the provider understand whether they should test for that type of kidney disease or kidney diseases that run in that general area of issues that can occur in the kidney. If someone shows up to the clinic and has kidney disease, but it's not at all clear why they have kidney disease, particularly if they're young and have no other reason to have kidney disease, that might prompt a provider to seek a genetic test to see whether they may have a genetic cause for their kidney disease.
Great, thank you. I think we have one more follow-up question, but we'll hold that until the end of the talk and come back to you. Thank you for that information. Now I'd like to welcome Kevin back to tell us a little about his journey to diagnosis. Kevin?
My name is Kevin. I'm 36 years old. I'm an only child, and I was born and raised in Long Island, New York. My entire life, I've been told I had something called microscopic blood in my urine in the medical world, microhematuria. Specifically, my mother and I were told we had a condition called benign familial hematuria. And as the name implies, it was something that we were told would not have any lingering or any negative effects on either of us for our lifetime. The fact that I had this benign familial hematuria was as normal to me as having freckles or being Irish. So there was really no secondary thought given to it. We had no paternal or maternal history of kidney disease in my family. Both my parents are also only children, so our family's pretty small. My only medical anomaly was that around the age of 20, I started noticing that I had a decline in my hearing. And this is something that I attributed to working part time at my college radio station and getting free tickets to go to very loud concerts and not wearing proper hearing protection at that time. I was a communications and English major at the time. And then at age 26, a few years later, I had started a brand new job in graphic design, and I started feeling extreme fatigue, muscle cramps, lower back pain, nausea, difficulty sleeping. And all of these things I attributed to the stress of starting a new job and possibly over exercising. I kind of wrote off all these symptoms as anything but kidney disease. And one day, my boss at work said to me, she said, "Hey, Kevin, you don't look too good. You should really go get checked out." And I appreciated her candor in saying that. And I went to a walk-in clinic because at age 26, I was bumped from my parents' insurance and I lacked all health insurance. I walked into that clinic and my blood pressure was so high that I was rushed to an emergency room about 15 minutes away. And at the emergency room, we did quick blood work and I was told that I was in renal failure. I had 7% GFR, so that's single digit 7% kidney function. My creatinine was almost 10. My potassium was dangerously high. And I immediately began dialysis that night in the hospital. So, needless to say, everything happened very quickly for me. A very short time later, a biopsy was performed on me. The first biopsy was unsuccessful, which the team thought was very strange. And we ended up doing a CT guided biopsy a short time later after that one, which successfully retrieved a sample of my kidneys, which we later learned were shriveled to the size of cherries from fibrosis. The biopsy revealed that I had X-linked Alport syndrome, and I realized that mom and I had an explanation for this blood in our urine that was not benign familial hematuria, but was in fact a rare disease called Alport syndrome, which affects the kidneys, the eyes, and the ears.
Wow, thank you so much for sharing that, Kevin. What did it mean to you to have a diagnosis, even if it meant nothing changed in your care? I'm sure that was very important and a relief.
Sure. So, at the time for me, the diagnosis changed everything. Most importantly, it explained that hearing loss, and it explained all the symptoms I just listed to you, which are things that a normal mid-20 something shouldn't have been experiencing. I think for me, the most important thing was having this Alport syndrome diagnosis allowed my mother to immediately begin treatment. At that point, it had been approximately 6 decades that she was misdiagnosed, and she could finally be on the correct condition for her correct condition. With that, I was also able to seek out other Alport syndrome patients. I assumed that there was no one else on this planet who could possibly have been misdiagnosed and went into end-stage renal disease. I soon learned a little bit after that unfortunately that's not the case. There are a lot of patients that are still undiagnosed or misdiagnosed, and finding a diagnosis after entering ESRD is more common than it should be. And that's why I'm glad to collaborate with the UCKD group to hopefully reduce the number of that occurrences.
Wonderful. Yes, you've been such a great contributor as part of the UCKD project. So we appreciate your work there and, of course, sharing your story with the audience today. Thank you so much. A reminder once again for the audience, if you're just joining us, welcome to our session on the importance of knowing the cause of your kidney disease. We will take questions at the end of our time today, but please start sending your questions and comments in now by typing them into the chat box. We will now speak with Holly. Holly, I'd like to give you the floor now just to talk a little about the recent legislation and the work that you and your team are doing as part of the UCKD project.
Thanks, Demetra. I'm Holly Bodie. I'm the Vice President of Government Affairs at the American Kidney Fund, and happy to be here today. We work on my team on federal and state legislation, and I'm here to talk today about some federal legislation that is still pending in this Congress. As many of you may know or may not know, the 117th Congress ended in December of 2022, and we started a new Congress, the 118th Congress, in 2023. And so bills that were introduced in the last Congress have to be reintroduced in this Congress. And there were several bills in the last Congress that focus on this issue that are yet to be introduced in this Congress. So I will give you bill numbers from the last Congress so you can look them up and just be assured that the American Kidney Fund and other organizations are working hard to make sure these bills get introduced in the current 118th Congress. So as Jamitra mentioned, we have a project going on at AKF called the Unknown Cause of Kidney Disease, and one of the subcommittees or committees working within that construct is a public policy committee. And we formed in September of last year something called the UCKD Coalition. And that was members of anyone on the Unknown Cause of Kidney Disease group that wanted to come together and provide a united front on public policy and federal legislative issues. So one of the bills that we engaged in, there are actually two primary bills that we talked about last year. One, this is a bill from last year, HR 7506. It's called the New Era of Kidney Disease, the New Era of Preventing End-Stage Kidney Disease. And this was introduced in the House, bipartisan, how a Democrat and Republican introduced it. And the bill addresses rare kidney diseases through research, training for health professionals, and other avenues. It also modifies requirements for Medicare drug plan formularies that include drugs for rare diseases or conditions. And so under this legislation, the Department of Health and Human Services would have to convene a conference focused on diagnosis and treatment of rare kidney diseases, study risk factors, access to care, including genetic testing, and other matters related to rare kidney disease, and establish grants for supporting kidney disease education and referrals in communities of color. And so that was a bill that was, custom made for our Unknown Cause of Kidney Disease Coalition. And we are working to get this bill reintroduced in this Congress. There's also a legislation that was introduced in the last Congress that we look forward to working on again this year, which is access to genetic counseling. So Medicare does cover genetic counseling, but genetic counselors are not paid directly by Medicare. In other words, they work for a hospital or a doctor, and they get paid through the hospital, not directly from Medicare. And so this legislation would ensure that genetic counselors are paid directly, which would make it much easier for patients to access genetic counseling services. And then finally, I just want to mention, this is not legislation, but it is a public policy issue and something that we've worked on, is that right now, the organization called the United States Preventive Services Task Force, that is a quasi-government entity staffed by volunteer physicians that decide what preventive services are recommended for Americans when they go get, for example, a physical. Right now, kidney screening is not recommended as a preventive test when people go to the doctor for their physicals. So we and other kidney organizations like the American Society for Nephrology and the National Kidney Foundation are working with the United States Preventive Services Task Force to ensure that to help get them to a point where they will recommend kidney screening, if not for everyone, for patients who are at risk, who might have a family history of kidney disease, who may have an unknown cause of kidney disease, who have high blood pressure or diabetes, the two leading causes of kidney disease. And so while that's not a legislative issue, it's something that's incredibly important to make sure that patients are diagnosed and screened early, so there's something so they can do what they can to treat their kidney disease. And with that, I will stop and happy to take any questions.
Great, thank you so much, Holly. We do have one question for you. If individuals or organizations would like to join the UCKD Coalition, can they do that? And if so, how?
Yes, so you can go to our website and look at the UCKD group, or you can also email me, and my email is hbode, it's B as in boy, O-D as in David, E @kidneyfund.org.
Wonderful. Okay, thank you. Thank you all for those few minutes that you spent talking. It's now time to take some audience questions, but first I'd like to remind the audience to visit the resources section on the Kidney Action Week website to view some resources related to this topic. We will start with a few questions, beginning with you, Dr. Gutierrez. Speaking to the number 2 cause of kidney disease, why does blood pressure impact CKD? And the second part of this question is, can low blood pressure impact CKD as well as high blood pressure?
Those are great questions. So there's a very close connection between blood pressure and the kidneys. And there is some evidence that if you have uncontrolled high blood pressure for a period of time, that can cause damage to the kidneys. And so there is some belief in the community that if you lower blood pressure, control your high blood pressure, you can protect your kidneys from the effects of high blood pressure. That being said, and I think this is an important point, oftentimes high blood pressure is a diagnosis of exclusion, which is another way of saying that is that sometimes when a physician or healthcare provider doesn't really know the cause of kidney disease, they will say it's high blood pressure, not because they're sure that's the case, but because they don't have a better explanation. And sometimes there is a better explanation that can only be discovered by doing genetic testing or by doing a kidney biopsy. And so it's important just to make sure, in collaboration with your healthcare provider, that if high blood pressure is thought to be the cause of your kidney disease, that they're thinking about other type of causes that might not be related to high blood pressure, and that can be tested so that the true cause is established and the proper treatment can be done. With respect to the other question, yes, if your blood pressure is low for a period of time, that could also cause problems with your kidneys, and we often see this in patients who have heart disease or liver disease. So either way, low blood pressure, high blood pressure can have adverse consequences on your kidneys.
Great, thank you. And one more question for you, Dr. Gutierrez. Can you expand upon the connection of both diabetes and blood pressure on the kidneys and why they are the top 2 causes?
So certainly with respect to diabetes, what's very well established is when you have high blood sugar over a period of time, this can cause inflammation and direct damage to the kidney tissue. And over time, this can cause the kidneys to work harder than they are used to, and this can cause the kidney tissue to wear out and eventually begin to decline over time. This is oftentimes very closely related to obesity as well, as obesity and diabetes are conditions that are tightly interlinked. And so whether you have obesity or diabetes, making sure that either your diabetes is very well controlled or that you're doing everything you can to lose weight in collaboration with a care provider is important for protecting the kidneys. And similarly, with respect to high blood pressure, controlling high blood pressure potentially is important for your kidneys, but it's even more important for other things like your heart and your brain and mental health. So for all those reasons, controlling your blood pressure is important for your overall health, in addition to your kidney health.
Absolutely, thank you. Kevin, we're going to turn to you for a couple of questions. What are some of the resources you sought out, and what was most helpful once your biopsy results came back?
Sure. So when the biopsy results came back, they told me that I had X-linked Alport syndrome. I was already starting dialysis in the hospital. My team was definitely already telling me, hey, you're a young guy in your 20s, you're pretty active, you're fit. You don't seem to have any other conditions outside of this rare renal disease. We want to talk about transplant as well. So there were so many things that I needed to wrap my head around. And I found myself on Google a lot. I had questions about dialysis modalities outside of hemodialysis, which I was doing temporarily in the hospital. I planned on switching to peritoneal dialysis to allow for more flexibility of schedule and hopefully a little bit better quality of life as well while I awaited a living donor, which thankfully I did receive a kidney transplant from my best friend 2 years later in May of 2014. But amidst all the internet searching, I found myself Googling Alport syndrome, and I found Alport Syndrome Foundation. I thankfully immediately connected with the co-founder and president of the organization. And the most important thing for me was, for the first time, kind of putting a pincushion on all the medical information I needed to know, and just talking to another patient that understood this, who understood what it's like to have other family members with this disease, who understood what it's like to be told you have a condition when you thought you were completely healthy, how a diagnosis like this can upend everything. And really, from the second that I felt the embrace of the renal community, specifically the rare disease community in the form of Alport syndrome and Alport Syndrome Foundation, I knew that this is something that no matter what was going to happen with my health, I wanted to spend the rest of my life working in patient support and patient advocacy. And so I would say to folks who still seeking out a diagnosis, or those who have it, either try to find other patients who are going through a rare renal diagnostic journey or just a renal diagnostic journey, or definitely find other patients who have your condition. I think it's one of the most empowering and rewarding things that a kidney patient can do.
Yeah, it definitely shows in all of your work, so thank you. We have a question about the symptoms you mentioned earlier. Does Alport syndrome impact eyes as well as ears? And does the hearing loss with Alport affect both ears equally, or can just one ear be involved?
Sure. So Alport syndrome is actually a defect in collagen type 4. So that collagen is found in things we call thin basement membranes, and those are actually found in the eyes, the ears, the kidneys, and other areas of the body as well, smooth tissues and other parts of the body that are lesser studied at this time. As far as the hearing loss goes, generally speaking, the hearing loss occurs at an equal rate in both ears. So that's called bilateral sensorineural hearing loss. We are aware of some patients who just have a progressive loss in one ear. Generally speaking, it is two. The eye abnormalities, we've seen reports as much as 10% of our community have reported this recently. And I think it's much higher than that, but a lot of folks are not being screened for eye abnormalities, or maybe their vision's okay, so they're not seeing an ophthalmologist who would actually be able to see other eye abnormalities only under certain testing conditions. My hearing loss, again, I attributed to just going to concerts all the time. So we know there are a lot of Americans living with hearing loss. So certainly there's no reason to equate that to kidney disease right away, right?
Right, absolutely. It makes a lot of sense. Thank you. Holly, we have a question that came in for you. What is the impact of getting a diagnosis on health insurance coverage?
So after the Affordable Care Act passed back in 2009, insurance companies cannot discriminate for pre-existing conditions. And so any condition that you have, the insurance company must cover it. And so there is actually no impact on your health insurance if you have a diagnosis of kidney disease.
Okay, that's great information. Thank you. Dr. Gutierrez, does someone always advance from stage 3 to stage 5, or can they remain in stage 3 with change in lifestyle and diet?
It is certainly the case that individuals can stay at stage 3 CKD or chronic kidney disease if they manage their condition as best as possible, whether that be diabetes or high blood pressure or whatever the cause of the kidney disease may be at the time. And that's always part of the focus of the kidney specialist and nephrologist, is to get them on a treatment plan such that they may not improve their kidney function back to normal, but at least they don't worsen and they don't have progression of their kidney disease, and they stay at stage 3. And I've certainly had many, many patients over the years who have stayed at stage 3 for years and years and years, never progressed, and have done well along those lines. So there's certainly, it's not a given that progression will occur. Each individual has their own sort of journey with kidney disease, but each individual has the opportunity to arrest the progression of kidney disease if they are put on the right treatment program for most causes of kidney disease.
Great. Another question for you, Dr. Gutierrez. Can you share about polycystic kidney disease as one of the causes?
Certainly, polycystic kidney disease is one of the most common genetic causes of kidney disease, and it's caused by a mutation in the gene that causes the development of these cysts, which are basically these sacs of water that occur in the kidney. And it's a condition that is passed from family member to family member, at least the most common cause, and can often affect individuals, usually found when they're younger, and untreated can result in the development of end-stage kidney disease by the time someone's in their 40s or 50s. And so it's really important. It's one of those conditions that if someone in your family has it, it's really important for other members of the family to be tested for it, because if it can be found early, then different things can be tried, certain medications and certain lifestyle changes to try to slow down the progression of the kidney disease as much as possible, and perhaps most importantly, get someone evaluated and planning for kidney transplant down the line if they were to need that, and start that process early than having to do that late in the process.
Great. Let's see. Kevin, question for you. How does your role at the Alport Foundation and as a member of the UCKD project allow you to share about the resources you wish you had access to years prior?
Yeah, sure. Myself and my colleagues often receive emails from suspected Alport patients. They have symptoms of Alport syndrome, and maybe they don't have an extensive family history or medical records just aren't available for them. And the good news is that, unlike me in 2012, when I did a biopsy, because that was really the gold standard at the time, here we are now, 13 years later, and we have financially accessible genetic testing options, multiple options, thankfully. And we know that genetic testing and getting an accurate diagnosis allows folks to get on treatment. As Dr. Gutierrez noted, identifying other at-risk family members, especially in hereditary renal conditions, access to patient advocacy and support groups like Alport Foundation, American Kidney Fund, and many other partners. And what was interesting for me was that in 2021, Alport Foundation surveyed our community. We had about 250 respondents to that survey, and 51% of the adults and 39% of the first diagnosed pediatric patients in the family were misdiagnosed. And that really struck me. All these years after my own diagnosis, misdiagnosis was still occurring at a relatively high percentage. The good news was that, in 2021, as part of that 250-person survey, we learned that 97% of adults who did genetic testing got a confirmed Alport diagnosis, and they had the ability to, again, begin treatment, identify these at-risk family members. This is compared to only 64% of those respondents who received the diagnosis by biopsy. So genetic testing certainly has been a game changer for the Alport community. We saw similar percentages, roughly 90 to 60% in genetic testing accuracy at 90% versus the biopsy with the 60%. So for the Alport community, I've witnessed firsthand, and by working with so many other patients, suspected patients and families, the tremendous impact that genetic testing can have for families. They can then go on to speak to a genetic counselor about family planning, what their particular mutation that's uncovered on their genetic testing report may mean in terms of the progression of their disease. Genetic testing to me just unlocks so many doors and so many avenues for treatment, better healthcare, better quality of life. And I cannot overstate the importance of genetic testing in our own Alport community. And now I get to share that as part of my work with the larger UCKD coalition to help spread the good word to other, renal conditions as well.
That's awesome. I like how you said it's a game changer, because that's definitely the case. Dr. Gutierrez, if a person had a parent die from renal failure, sepsis, and have cysts in the kidneys, should genetic testing be pushed?
Well, it really depends on a number of different factors. It is not uncommon for individuals as we get older to develop cysts in our kidneys, which are not the same thing as polycystic kidney disease. These are sort of cysts that will develop in many older individuals that are not thought to have are not thought to be connected to a pathological process or a process that causes kidney disease. It's just the natural part of aging, and so the observation of cysts in someone who's developed acute kidney injury, kidney damage in the setting of sepsis does not necessarily mean that someone has polycystic kidney disease. Polycystic kidney disease in an older individual is very hard to miss because by the time you get to past really the age of 50 or 60, if you have polycystic kidney disease, your kidneys will be mostly cysts. And a pathologist or a radiologist wouldn't miss that per se in the vast majority of cases. And so really, if you have a question about it, would talk to the healthcare provider, get some more information about the cysts, and ask them whether a pathologist or a radiologist felt that there's polycystic kidney disease or could possibly be. If the pathologist or radiologist feels like that's the case, then I think testing would be indicated. If they feel like it's very unlikely that's polycystic kidney disease, then I think there's probably other reasons why that person developed kidney failure.
Thank you. I know that was a quite specific question. Kevin, I wanted to talk a little bit about mental health resources and ways that you coped, in the beginning of your journey. What are some of the mental health resources that you turn to?
Dealing with everything from being a 26-year-old who is now told he was quote unquote disabled and had to learn about Medicare and Medicaid. I lost my job because I was in the hospital for so long. And as someone who was an active 20 something, I'd be on the internet, on the social media channels, watching my friends go out and do things that normal people in their 20s would be doing, going on vacation, going out to restaurants and bars and enjoying their youth. So it was a tremendous mental toll on me. I think a lot of it I pushed to the back of my mind because I was focused on just surviving as someone who had to go to dialysis every day or be attached to a cycler for 10.5 hours every night. In retrospect, I certainly wish that I had been referred to or been offered a mental health specialist. I know that this is something that is more and more becoming part of a renal care team. And I certainly applaud all institutions that are doing that, especially in pediatrics. My hospital where I ended up receiving treatment happened to be the only pediatric dialysis unit in my area. And I saw children, as young as 8, 10 years old in dialysis. And it really kind of hit me that, if an 8 or 10-year-old can get through dialysis, I could get through it in my mid-20s. That kind of made me want to talk to other patients right away. I immediately connected with other patients my age that were going through dialysis. And after the first few phone calls that were, tough to kind of share this burden together. Next thing we knew, we were kind of laughing about various aspects of treatment and things that made us frustrated when we were doing treatment. And I think just that patient connection and talking to someone else who's been through what you're going through. It's really hard to find a therapist or mental health professional who's going to be intimately familiar with the ins and outs of kidney disease. You may be able to find a mental health professional who does speak to dialysis patients. That might be the best you're going to get. But still, whether you seek professional help in that avenue, or just seek other patients and families who are going through kidney disease, end-stage renal disease, whatever part of the renal journey you're on. Certainly, the mental burden can change as things progress towards stage 5. But even those that are in stage 2 and 3, I would still encourage them to reach out to other patients too and feel part of like the larger renal family.
Fantastic, thank you. Polly, can you talk a little about efforts that our audience members can kind of turn to for lobbying or advocating for expanding coverage for genetic testing, maybe on the state level?
Sure. So one way they can get more involved is to join the American Kidney Fund's Advocacy Network. Again, you can go on our website and sign up for that. I also encourage people to figure out who their, not just their member of Congress is, but who their member in their state legislatures are. And people in the state tend to be much easier to reach and much easier to have meetings with. And I think patients have a really powerful voice. Kidney disease as we have discussed, and I'm sure most people listening to this know that there's such an epidemic, and so many people don't even know the basics about kidney disease. And so I think there are really great opportunities for patients and caregivers and people who care about this issue to reach out to their state elected officials and to their federal officials and just give them the basics about what kidney disease means, what it means to have an unknown cause or a rare kidney disease, that access to diagnosis, to genetic counseling, genetic testing, and treatment is really important. Don't assume that people know anything, because most people don't know much about kidney disease, and they certainly don't know much about rare kidney disease. So I just encourage people, again, to sign up to be an advocate with AKF, but also, take it upon yourself to make connections with your elected officials.
Right. You mentioned caregivers, and we have a question for Kevin regarding caregivers. Can you talk a little about your support system and your family and how they coped with this kind of new normal that you discovered in your journey to diagnosis?
Yeah, sure. So as I mentioned earlier, Alport syndrome is a hereditary condition. I'm an only child. Both my parents are only children. So I joke that we don't really have a family tree. We have more of like a family shrub, I call it. And, it's a lot easier to be diagnosed with Alport syndrome and some other conditions when you have extensive family history. Someone along the line probably would have went on dialysis or maybe died prematurely of a cardiac condition or, very plainly of kidney disease. It'd be a little bit more obvious that this is in my family. So for me, my mom and I found out about it the same time. As soon as my biopsy results came back, it explained what our benign familial hematuria really was this progressive kidney disease, Alport syndrome. So I think one thing I see a lot in the Alport community, because it is hereditary, is there is this feeling of guilt. Especially from moms who pass it on. And I think that's unfair to dads, because in Alport syndrome, it can be passed along by the father as well. But we seem to focus on the moms and the feeling of guilt of unintentionally passing on a condition to their child. And I know my mom felt that, but at the same time, she was going through this kidney journey the same time I was. And in a way, we were kind of both in this boat together. We were both misdiagnosed for a long time. We both were denied the ability to get proper treatment for a long time. So I think, we were in this thing together. And even though I was unfortunately at the point where my only treatment options were dialysis and then subsequently transplantation, my mother kind of had a much more clean slate. We knew what medications to get her on, and really all the focus kind of went on her, which was good because I was getting kind of tired of all eyes on me in the hospital all the time. And I think it was something that certainly brought my mom and I much closer together than, I never would have expected that we would be sharing, a health condition that basically went from being non-existent in our lives to a household conversation almost every day. So, I'm grateful that my mom and I had each other for that. I'm grateful to still, have both my parents. I know, other patients who might not have such a tight support system. So, my mom and my friends, as someone mentioned before, I apologize, too. Most folks don't know much about kidney disease. So I had to explain to my friends what dialysis was and why I was on it. And, folks didn't understand, why are you cold and shivering all the time? What does that have to do with your kidneys? And I'd explain about anemia and red blood cells. Most folks don't really know about kidney disease. So it opened my eyes to being more open to just talking to folks and educating them about it. And I think once I just educated my friends about kidney disease, they had a lot of really good questions. They seemed to be more invested in my care than before. And, folks were then interested in helping me try to find a living donor when they learned, how grueling dialysis was.
Right. So many layers of conversation just getting to your diagnosis, but the whole the kidney disease part of it as well as the rare disease part. So just kudos for, your journey, because that just shows that everyone has a unique journey. No journey is the same. So thank you for sharing that. A question for Dr. Gutierrez about kidney-friendly diet. At stage 3 kidney disease, do you treat or cause or focus on a kidney-friendly diet at that point of the diagnosis?
I think it's fair to say as soon as you know that you have any stage of kidney disease, taking any measure that you can to reduce the risk of progression of kidney disease is important. So whether that's at stage 3 or even stage 2, embracing a kidney-friendly diet is always a good idea, because a kidney-friendly diet oftentimes is also a heart-healthy diet, and it's a brain-healthy diet. You want to protect all three aspects, your heart, your brain, your whole body. So for sure, the sooner you start any treatment for a kidney disease process, the better, and the more likely it'll be effective in terms of reducing progression of that kidney disease.
Thank you. Another question for you, Dr. Gutierrez. What is the life longevity after kidney transplant?
It's a great question, and it depends a little bit about on the type of kidney transplant. And so there are two different types of kidney transplants right now, at least, that we have available to us. One is a kidney transplant that you get that someone who's living donates to you. It's called a living donor kidney transplant. And then there's a type of kidney transplant that you get from someone who's deceased, who's died for no other reason, and then donate their kidneys after death to an individual. That's called a deceased donor kidney transplant. Living donor kidney transplants tend to last longer than deceased donor kidney transplants, and nowadays they last, generally speaking, living donor kidney transplants will last over 10 years before either wearing out or you require a new transplant. For individuals who have deceased donor kidney transplants, so that's one you get from someone who's passed away, tends to be shorter than a living donor kidney transplant. Though when I started, how much shorter is getting better over time. When I started training, the typical deceased donor kidney transplant would last 7 to 10 years. And I think with improvements in the care of these individuals, we're seeing these transplants last longer and longer, and certainly know of individuals who've had kidneys from people who are deceased who have lasted 20 or 30 years if they do a really good job of taking care of them. So the key is taking your medications, taking care of your kidneys, and they will take care of you in the long term.
Absolutely. Well, thank you all for answering all of those great audience questions. We appreciate the audience for the questions and the panelists for being with us. We'd like to start wrapping up, but before we do, we would like to ask each panelist to leave us or leave the audience with 2 things to know and 2 things to do based on today's discussion. So Kevin, we'll start with you.
Yeah, sure. So I would say for patients that are still seeking an accurate kidney diagnosis, please know that you're not alone. Certainly, I was living proof that there are lots of folks out there who are still awaiting a proper diagnosis, and there are a lot of positive things that can come from getting the diagnosis. Admittedly, that journey may be filled with obstacles, but it's important for you to continue to advocate for better answers and care. So I would say just remember you're not alone, and keep advocating for better answers and better care. As far as things to do, I think if you are a patient with unknown cause of kidney disease, please do everything you can to do your research, consult with your nephrologist, and seek out genetic testing. I think a lot of the thoughts around it, 10 years ago about the cost and things of this nature, a lot of those obstacles, while they still exist, genetic testing is certainly more financially accessible than ever before. So I would say please pursue genetic testing. And secondly, as I mentioned earlier, another thing to do is talk to the renal patients. If you don't know your disease type, you can still talk to someone, whether it's PKD or Alport syndrome or IgA nephropathy. Despite the nuances of all these different renal diseases, we all ultimately share common obstacles and ups and downs and mental health struggles. And it can certainly help you with your mental health to know you're not alone on this diagnostic journey, which can admittedly still be long.
Thanks, Kevin. Dr. Gutierrez, what are 2 things to know and 2 things to do that you'd like to share with the audience?
Well, I think 2 things to know. One is just, would like to emphasize again that oftentimes people are assigned hypertension as the cause of their kidney disease, and Again, sometimes they're assigned that because the care provider doesn't have a better cause, but there might be something else that is discoverable with genetic testing or biopsy. So if someone tells you you have kidney disease from hypertension, just press them on that and just make sure that they've looked at other potential causes. And the other thing is that that genetic testing is increasingly available in the office and in different commercial products. So if you're interested or if you have a family history, please do ask about that. Two things to do. If you have a high risk condition, if you have diabetes, if you have high blood pressure, if you're overweight, or if you have a family history, for example, please do make sure that your care provider has tested your kidneys and that you know what that test result shows. So that's one thing to do. And the second thing to do is to make sure that you keep a good family history and you keep in contact with your family members. I think it's never, it surprised me over the years. Sometimes you ask someone who's seen kidney disease, if you have family history of kidney disease, they say no, and then they start talking to their family members, and they find out, oh, actually, their aunt, their uncle, their grandmother actually had, was on dialysis, had kidney disease. So, talk amongst yourselves, know your family history, and that will do you well in terms of preventing potentially worsening kidney disease or kidney disease in your children down the line.
Awesome, thank you. And Holly?
Two things to know is that AKF groups like Kevin's group, the Alport Foundation, other kidney organizations, other rare disease organizations are doing what we can to educate members of Congress and state legislators about rare kidney disease. And you should also know your voice counts. You're a constituent of people at the state and federal level, and people will listen to you. So what you can do about that is you can sign up to become an AKF ambassador on our website. And then you can also, like I said earlier, figure out who your member of Congress is, who your state representative is, follow them on Twitter, follow them on Instagram, engage with them on social media. And again, especially at the state level, your voice can be heard directly by the member. I think really getting to know your state legislator and reaching out to them can really have a big impact.
Great, thank you. Well, I'd like to thank our three panelists for joining us today. We covered some very important information that we hope you find helpful. Please remember to visit the Kidney Action Week resources section. You can also follow us on Facebook or send an email through kidneyfund.org to find out about additional resources like this. You can also visit our website to learn more about our Unknown Causes of Kidney Disease project. We have more great sessions in store this week, so please join us tomorrow at 2:15 p.m. Eastern Time for the How to Find a Living Donor session. Once we conclude this session, you will see a poll for a quick survey pop up. Please take a minute to complete it and tell us how we did. Your feedback will be very useful as we plan future sessions. Thanks, everyone, and we hope to see you back tomorrow.